Hello, and today topic we'll be dealing with is cyst. Apart from abscesses, the most common conditions that a physician or surgeon generally sees are tumors and cysts. Cyst is nothing but it is actually a collection or a fluid-filled, soft, fluctuant swelling which is actually lined by an epithelium, either epithelium or endothelium. These cysts are of various types like true cyst and pseudocyst. True cyst is nothing but it is actually lined by an endothelium or epithelial layer, whereas pseudocyst, as in appearance, it appears like a cyst. However, it is not usually lined by any epithelial it is not covered with any epithelial or endothelial lining. So we'll be dealing about various cysts that we actually see, acquired congenital cysts, etc., and how do we actually manage them. So cyst is actually derived from a Greek word. This means bladder because it appears like a well distended fluid sac structure. It is called as cyst and it is derived from a Greek word which means bladder. Coming to the classification of cysts can be they can be broadly classified as based upon the lining. As I said, they are actually lined by an epithelial or endothelial lining, right? So they are actually based on this, they are classified as true cyst or pseudocyst. True cyst is something which is actually lined by an epithelium. Pseudocyst or false cyst is not lined by any epithelium. However, in true cyst, what happens is, in the process of its healing, sometimes other than this epithelial or endothelial, it can either be lined by a granulation tissue lining also. So that can also be a lining material in case of your true cyst. When you're talking about pseudocyst, these pseudocysts are again various types like exudation cyst and degeneration cyst. When you're talking about exudation cyst, these exudation cysts are nothing but they are actually fluid which has been moved into your anatomical spaces. Okay, it is probably because of any blockage or it is collection of fluid within the anatomical spaces, and this appears like a fluid filled sac. However, it is not lined by any epithelial layer other than lining. It is just a fluid that has been leaked into your tissue spaces. So it can be like pseudopancreatic cyst, which is again an example of your exudation cyst, and in oral cavity also we can see something like mucus retention system, mucus extravasated cyst, right? So one of mucocele can be a mucus extravasation cyst, which is because of any puncture along the salivary gland duct where there is leakage of the saliva into adjacent tissue spaces. So it is again an example of your exudation cyst. And when you're talking about degeneration cyst is again a type of pseudocyst. Here what happens is, in degeneration cyst, within the center of a malignancy, then what happens, it can have a type of necrosis, like it can be either an ischemic necrosis or a coagulative necrosis can happen, or it can be any hematoma formation within this center leading to degeneration cyst. Okay, so these are about how we classify based upon their linings. Based upon their origin also, we actually classify cyst into two types. One is congenital cyst and acquired cyst. So when you're talking about congenital cyst, we have various type of cyst, and most common one are dermoid cyst, and these dermoid cysts are like sequestration dermoid, tubuloembryonic dermoid, and cyst of embryonic remnants. When you're talking about the sequestration dermoids, they're actually formed along a line of closure. In sequestration dermoids, what we have is, along the lines of closure, what happens, there will be epithelial remnants gets entrapped between these lines of closure, leading to the sequestration dermoids. Usually the sequestration dermoids are seen in the midline structures, like midline of the neck, midline of the in between your symphysis mentae, which has to be actually fused after after the age of 1 year. Normally this will be fused. When this is not fused, what happens is, within the midline there will be, along the embryonic cleft, there will be entrapment of these epithelial layer, leading to this sequestration dermoids. Example of the sequestration dermoid include like branchial cleft cyst. When talking about tubuloembryonic dermoids, normally this tubuloembryonic dermoids occurs in the tract of your ectodermal tube, and along the ectodermal tube this tubuloembryonic dermoids can occur. Example of this is again along the tubular, we have thyroglossal duct cyst, right? Thyroglossal duct cyst or thyroglossal cyst itself. So normally it has to fuse, and without this earlier closure, it extends into formation of a cyst again, leading to this tubuloembryonic dermoids. We are talking about cyst of embryonic remnants. In the cyst of embryonic remnants, for example, we have cyst of urachus. Okay, this is again an example of your cyst of embryonic remnants. We have some other cysts which are actually acquired, and these acquired cysts are of various types again. We have retention cyst. Retention cyst could be, for example, in this picture we can see mucus retention cyst. It is usually because of a blockage of the duct. For example, salivary gland duct is present, or for example you have Bartholin's cyst, or we have a mucus retention cyst, we have parotid cyst. In this, what happens is, along the line of the duct there could be some caliculi. Calculus is or silolith, which is nothing but a calcified material is present. So this calcified material will not allow your free flow of saliva, leading to obstruction, and this causes retention of the fluid inside, leading to a cyst. So these are nothing but your retention cyst, which includes parotid cyst and pancreatic cyst. And when we are talking about distension cyst are nothing but it is distension of the normal acinar material. Okay, and this, because of this distension of normal acinar material, what happens is it forms into a cystic, these cells are forming, will just get distended and they later form into cyst-like condition. Example, we have thyroid cyst and ovarian cyst, which are nothing but examples of a distension cyst. And when we are talking about exudation cyst is nothing but again, this fluid is moving into our anatomical spaces, and this, because of this fluid leakage into the anatomical spaces, then this exudation cyst occurs. Exudation cyst example again, mucus extravasation cyst, which is nothing but your mucocele within the oral cavity, usually formed in the cyst of a lips, the lower lip most commonly seen, where patients usually have this lip biting habit. When they continuously or constantly bite the lip, what happens? They cause traumatic injury to the ductal lining. With this traumatic injury to the ductal lining, what happens? The fluid within this will come into the anatomical spaces, leading into this exudation cyst. And in exudation cyst, we also have bursa, which is again another example. Now coming to degeneration cyst, as we have earlier seen, degeneration cyst is nothing but within the center of your malignant tumor, or within the center of the tumor, what happens? Various types of necrosis like coagulative necrosis can occur, or a hematoma can occur, or ischemic necrosis can occur, leading to cystic formation. That is nothing but degeneration cyst there. And we have something called cystic tumors. Cystic tumors are nothing but some, for example, benign tumors like ameloblastoma of mandible. What happens is it can manifest as a cystic ameloblastoma or unicystic ameloblastoma, where it has more amount of fluid content within it. Okay. Even we have dermoid cyst of ovary, which is again an example of your cystic tumor. Next, we have something called implantation dermatoids. Implantation dermoids are nothing but they are, for example, there was a blunt injury happened, probably a needle prick or a blunt knife injury. During this process, what happens? A superficial epithelial layer get entrapped into these penetrating wounds, leading to implantation dermoids. The name itself tells it is just an implanted dermoid with or implanted cyst within the trauma area, the area that has underwent trauma. Now, for example, these implantation dermoids are usually seen on the fingers, on the legs area, on the feet area, wherever it has more, propensity for traumatic areas. Next, we have something called as traumatic cyst. These traumatic cysts are usually, they are caused because of trauma, as the name itself indicates. When a trauma happens, what happens? There will be hematoma formation. Most of the times, this hematoma gets resolved, but instead of resolving, this hematoma itself converts into cystic material, gets necrotized. It undergoes some coagulative necrosis within itself, leading to a cystic fluid consistency, and this itself manifests as a traumatic cyst. And in traumatic cyst, the characteristic feature is when we actually aspirate the fluid, you get this blood color fluid or brownish, straw color fluid, brownie mixed with the blood, which itself shows that there was a hemorrhage earlier, which has underwent some kind of necrosis, leading to cystic consistency. Then we have parasitic cyst. Parasitic cyst, as the name itself tells us, that it is mainly because of parasitic infections, and the most common one which we see is hydatid cyst, and we also see cysticercosis. This is because of Taenia solium, and hydatid cyst is because of Taenia echinococcus. Okay, and cysticercosis, here we see a picture of hydatid cyst. Even cysticercosis also because of having pork meat or beef, or it is because of or even unwashed vegetables also, which are grown near the butchering area or in places where there are more amount of pigs which are present there also can lead to this cysticercosis. What happens in cysticercosis is because of this ingestion of this larva, it enters into the tissue spaces leading to a cystic formation, and this is usually well encapsulated cyst. On palpation also we can see that cystic consistency, but what happens is it is because of its well encapsulation that proper cystic features would be missed in case of this parasitic cyst. And in parasitic cyst also we can see calcifications, which is again an other pathognomic feature of this parasitic cyst, especially cysticercosis. So we have seen how they are actually classified, various types of classification, both as congenital classification and congenital cyst and acquired cyst. Now how do we actually clinically examine them? What are the clinical features of those cysts? Before going into clinical examination, history also gives us some insight into what kind of cyst it is. For example, duration of the cyst. So whenever we are asking a patient about duration of the cyst, ask for how long it is present. Is it present right from the birth, or it has been after any trauma it has developed, or it was somewhere in between the age group or in between the developmental stage. So this gives us an insight. For example, if it is present right from the birth, we can think about dermoid cyst again. I mean, we can think about the congenital cysts that are usually present, or after any trauma it has occurred, we can think about some implantation cysts there. So based upon the duration, from how long it is present, and based on origin also, from where it has developed, in which place it has been developing, will also give us an insight. And we should ask about pain. Is the cystic swelling painful or painless? Normally most of the cysts are painless. If the patient complains that there is any pain within the cyst, then we have to think about any secondary infections that are acting at that place. Okay, so if there are any secondary infections or because of that inflammatory reaction, the cyst becomes painful. And any growth, is the cystic swelling same in consistency, or is it growing in size? For example, this growth also will give us an insight. For example, mucus retention cyst or mucus extravasation cyst, what happens is, because it is normally seen on the lower lip region, right? So when we are seeing this mucoceles or any retention cyst, when we ask about growth of the cyst, patient usually gives us a history that before eating, or when patient is eating, during the time of this, before, during and after eating, this cyst usually grows in size and later it comes back to its normal size. This is because when we are eating, what happens, more amount of salivation occurs. So when there is excess salivation that is been coming out through the ducts, what happens, this swelling keeps growing and it comes down to its normal size little later. Again, this growth also, if there is cystic swelling that is growing in size for continuously growing in size, we can think about some cystic tumors there, which will also, this growth helps us. If the growth is very rapid, is the growth very slow, or there is no growth at all. So growth will give us an insight into what kind of cyst it is again. And general health. Why general health is important? Because as I said already, tumors, some kind of tumors, or especially your degeneration cyst. Okay, degeneration cyst occurs in the malignant tumors. So we have seen that it occurs in the center of the tumors. So when you're suspecting any malignancy which has undergoing cystic necrosis or cystic changes have been happening with it, then we should also ask for the general health of the patient. Why it is helpful? Because it helps us in general health. If patient is having loss of weight or loss of appetite, if patient is hypochondriac, then we can actually think of malignant terms also when we see that kind of swellings. And coming to inspection, site of an infection, site of the cyst usually gives us half of the diagnosis. When we're talking about site of the cyst, usually, as I said, dermoid cyst will usually present along the midline. Thyroglossal duct cyst is present along the, in connection to your thyroid, because whenever patient swallows, when there is a deglutition, what happens, there is movement of this thyroglossal duct cyst along with it. So site gives us an insight into what kind of cyst it is. When you're talking about number, is it a solitary cyst or is it a multiple cyst? Why? Because sebaceous cysts are usually multiple in number. So by number also we can come to some kind of diagnosis. And surface, usually the cyst surface are well smooth surface is present, and also the margins are well defined in case of cyst. So based upon this also we can come to a conclusion. Then palpation. Palpation is surface and margin. Usually cystic surfaces are smooth and the margins are also well defined, and usually they are fluctuant. Any cyst is, when it is filled with fluid, it is usually fluctuant. That is nothing but when we actually fluctuancy we can test like this. When we are, it is nothing but water in a balloon. Okay, when you pour water in a balloon and tie it, we have a balloon ball, right? When you press it one side, fluid comes in the other side. When you press it in the other side, fluid comes from this side. So it is nothing but fluctuancy. This is how you test for fluctuancy. Between your two fingers, you try to check for fluctuancy. And consistency. Usually cystic fluids are soft in consistency, and they have, if the fluid is completely filled, that usually tense. And in case of large cyst, we can find fluid thrill. And translucency, usually cysts are super translucent. They have brilliant translucency can be seen in case of cyst. And translucency usually in case of we can see in cystic hygroma, usually translucency is very well defined there, very well pronounced there. And this is about how we examine, how we actually take history and how we examine clinically about cyst. Now when you're talking about what are the complications that occur within the cyst. In complications of cyst, one is infections. Secondary infections of cyst can occur where it becomes painful, and sometimes if it is not resolved properly within time, this can turn into an abscess. If that is also not treated properly, then that inner pus can come out via a sinus opening, or it can also form into an ulcer. Hemorrhage, usually cystic lining sometimes can undergo hemorrhage, and if there is this hemorrhage into the cystic fluid or into the cystic contents, then remember, cyst can become painful. So if there is any cyst for a longer time which was not painful till then, and suddenly pain arises within it, then suspect some hemorrhage within this cystic fluid. And then torsion is also usually seen in case of ovarian dermoids. And calcifications, as we already discussed, calcifications are one of the most common features in case of especially the parasitic cyst like cysticercosis, and also in the hydatid cyst we can see this kind of calcifications. And when we're talking about dermoid cyst is usually lined by the skin material. And it is also called as epidermal cyst. It is called epidermal cyst because the lining is usually by squamous epithelium, and this epidermal cyst or this dermoid cyst usually contains pultaceous material. Earlier actually in the cyst, what happens is it is either the material of the cyst can be of two types. One is either it is a mucus or the serous fluid can be present, or it can also have a toothpaste like pultaceous like material. It is a combination of either it can be sebum, sweat, or these desquamated epithelial cells can come down and they necrotize, forming this pultaceous or toothpaste like material. Similarly, in our dermoid cyst also we have this pultaceous kind of material. These dermoid cysts are actually classified into four types. One is sequestration cyst or implantation dermoid. We have tubular dermoid and teratomatous dermoid. When we are talking about sequestration dermoid, it is usually a congenital variety, and this sequestration dermoid usually happens because of the implantation of your squamous epithelial material. This sequestration dermoid is at the epithelium is usually based in the line of your embryonic fusions. At the embryonic fusion line, this epithelial cells get entrapped and this forms into sequestration dermoid. What happens here, how the pathogenesis is, the epithelial cells that are actually been entrapped within itself can undergo coagulative necrosis. They undergo necrosis. These ectodermal cells especially get sequestrized into the upper layer. They undergo necrosis or they liquefy. They form a cystic material leading to a sequestration dermoid cyst. The most common sites of this sequestration dermoid, the pathognomic feature is midline. Usually dermoid cysts occur in the midline. Midline because they are at the line of your embryonic fusions. Along the embryonic fusions, these dermoid cysts occur. So most commonly, these occur along the midlines. So they present along the midline of the neck. And second thing, also present along the outer canthus of the eye. That is also called as angular dermoids. Here in the outer canthus of eye, what happens? It is because of the fusion of your bony structures. We have a suture there, right? Along the suture, along this fusion, there can be entrapment of these cells leading to embryonic cells, leading to the cyst, the dermoid cyst along the angular or outer canthus of the eye. We have midline of the neck in the outer canthus of the eye, in the post-auricular region similarly, and also in the skull, and we also see this sequestration dermoids in the skull. These are the common sites. And when we're talking about the origin, usually the origin is because of this entrapment of the cells along your fusion of the embryonic lines. Now coming to clinical features. Normally in the clinical features, coming to history of it, usually this sequestration dermoid are present at the time of birth. However, for the cyst to develop, it may take some time, and usually they are observed, or they are seen usually in the few years of the life, first few years of the life. When we're talking about the symptoms, they're usually painless swellings and they grow very slowly. These sequestration dermoids are painless swellings and they grow really slow, and these swellings usually, the primary concern of the patient would be cosmetic disfigurement. Okay, the primary concern is cosmetic disfigurement. The patient is aesthetically bothered about it. However, they're not so very large, or they are not so very hampering, causing any mechanical obstruction. That usually do not cause any mechanical obstruction and or any mechanical disability. Then only the primary concern would be your cosmetic disfigurement. So when we are examining it, usually the presence of it, the site of it will be along the lines of your fusion, along the line of the fusion, and they're usually smaller in size, about from few millimeters up to 2 centimeters in size, usually greater than, sometimes they are greater than 2 centimeters in size. And clinically when we examine, usually they are soft because of the pultaceous material that is present there, and the characteristic feature, they does not have any punctum. In sebaceous cyst there will be a punctum, whereas in your dermoid, especially sequestration dermoid, there will not be any punctum. And this pultaceous or toothpaste like material is usually white or creamy or cheesy white in color, and it is because of that consistency, it is usually softer in color, softer in consistency, and there will not be any transillumination here, negative transillumination, because it is not a clear fluid, it is actually a thick paste like material, and hence the light cannot pass through it because of its opacity. And remember, there is no transillumination positive here, so transillumination is negative. And these cysts are soft in consistency, but they are neither compressible nor reducible, okay, because of the thickness of this material. When we are talking about the radiographic findings, what happens is, as I said, they are along the lines of the fusion, right? So because of this entrapment, the cyst can grow in size. If it is growing in a larger extent, it can cause depression on the bone. Okay, when we are taking an X radiograph, the bone can show a radiolucent depression. It can be slightly radiolucent when compared to other adjacent structures. Sometimes there can be gap in the bone because of the growth of this cystic lining along the fusion lines. So in between, normally they have to fuse, but because of the cyst that is growing in between, there will be a gap between the bony structures. Okay, the treatment is usually complete excision if the bone is being involved there. Sometimes what happens is this extension of the bone, extension of the cyst can be either pericranial or even intracranially occurring. So instead of local anesthesia, here this surgery has to be done under general anesthesia, because we are actually managing by treating this very delicate structures there, because it can the cyst can grow even into intracranial structures. So the treatment for it is again complete excision of it. Then we are talking about implantation dermoid. And implantation dermoid is, as we have already discussed, it could be because of the implantation of the the stratified it is usually lined by stratified epithelium, and it is because of the implantation of these cells because of any minor or sharp or blunt trauma. What happens, usually seen in butchers or in tilers, usually who are actually meddling with or handling very sharp instruments. Okay, because of this implantation, what happens is, because of this minor trauma along this penetrating wounds, what happens, the superficial epithelial layer gets implanted, it gets entrapped between these traumatic structures. When these disformated cells get entrapped, they later liquefy, forming a cyst consistency, forming a cyst there. It is nothing but our implantation dermoid. And the common sites for this implantation dermoid is usually the fingers, especially the pulp of the fingers, and the feet or the sole of the feet, which are usually which can be harmed because of this sharp pricks or because of thorns, etc. So pulps of the fingers, sole of the feet are most common sites for this implantation dermoid. And this implantation dermoid the consistency of it is usually white cheesy material. Why white cheesy material? Because of the desquamated cells which have been entrapped gets liquefied. Because of this cellular material, it appears as white cheesy material. Remember, there is usually no hair in this implantation dermoids. It is only because of the cells that has been entrapped getting liquefied. Because these implantation dermoids are usually very small in size. They usually are not very big in size, usually very small. Because of this smaller size, what happens is they usually firm. They are slightly firmer in consistency when we are comparing to other normal dermoid cysts. Also because, as I said, it is because of a pricking, right? Pricking or any sharp injury. So we can see that prick scar on the surface of the cyst. Skin on the cyst lining will be present, the outer cyst lining will be present, right? There sometimes we can see a scar. Usually, as we said, the history could be a repeated minor sharp trauma. Most of the times what happens is patients tend to forget what would happen. So by eliciting the history, properly asking the question, is there any trauma, or how did this happen, what was an incident that happened before developing this cyst, etc., could give as a proper insight into whether it is an implantation dermoid or some other dermoid cyst. Now coming to clinical features, as I said, history of any prick or trauma, and symptoms are usually it is a slightly painful swelling. It is not completely painless as your sequestration dermoid. It is slightly painful and smaller in size, and it is actually a tense cystic swelling. Because of this tense cystic swelling, pain is usually produced, usually seen on the finger or palm with a history of punctured wound. The pathognomic one single line for this is tense cystic swelling on the finger or palm with a history of punctured wound. This is a single line which explains completely about your dermoid cyst or implantation dermoid. And complications are secondary infections can be seen, which may make the cyst more painful, and bursting can be seen because of high tense cyst. Because of its tense nature, it can burst, leading to that fluid coming out of it. It can become into a ulcer later, and suppuration is also one other complication of your implantation dermoid. Management, again, if it is a very small cyst, better you do a complete excision. Even for a larger cyst also, complete excision along with the whole complete borders of it is the treatment of choice. And now we are talking about tubular dermoid cyst. Tubular dermoid cyst is usually because of your unobliterated portion of your congenital ectodermal duct or tube. Most commonly we can see thyroglossal duct cyst. Usually thyroglossal cyst or thyroglossal duct cyst is because the remnant of your unobliterated portion, it is not obliterated. It was remained in the along the embryonic fusion. In the process of embryonic development, what happens is it has been remained. So from unobliterated portion of your congenital ectodermal tube or duct, what happens is this tubular dermoid cyst usually develop. We have three different types of tubular dermoid cyst, and one is thyroglossal cyst, as we already explained. Thyroglossal duct cyst, it is usually also called as tubular dermoid cyst. We have post-anal dermoid, and we have ependymal cyst of the brain. Post-anal dermoid is now simply treated as a teratoma, whereas ependymal cyst of the brain is because of your infolding of neuroectoderm. Because of the neuroectoderm infolding, this ependymal cyst of brain is formed, which is again a tubular dermoid cyst. And we have something called as teratomatous dermoid. As the name itself indicates, it is teratoma. It is develops from your totipotent cells, and it has all types of mesenchymal cells present with it, and it contains bone, it contains cartilage, it contains tooth material, it contains hair within it. These are all different materials that are present in a teratomatous dermoid. Usually this teratomatous dermoid can be seen in ovarian cyst. We can see in a testis teratoma is present. We have retroperitoneal and also mediastinal teratomatous dermoids are present. And when you're talking about the management of these dermoid cysts, the primary thing is excision. Always it is better to excise this dermoid cyst for better prognosis of the patient. Usually dermoids are not very severe life-threatening conditions. However, they pose an aesthetical disfigurement or aesthetical challenge to the patient, and hence removing of complete excision of this dermoid cyst is useful. Now let us talk about sebaceous cyst. As the name itself indicates, sebaceous cyst is a cyst which is related to sebum producing glands, right, through sebaceous glands. Normally the sebaceous glands are present, they actually secrete something called as sebum, which will keep the skin supple, moist, and it prevents it from drying off. Sometimes what happens is, if there is any blockage onto the duct, normally these sebaceous glands open up into the hair follicle or sometimes directly onto the skin, okay, through a ductal opening. Sometimes if this ductal opening is been blocked, what happens is with its own secretory fluid, that is the sebum, this sebaceous gland it gets distended, and this leads to sebaceous cyst. So it is also called as retention cyst or epidermoid cyst. It is called as epidermoid cyst because it is usually lined by stratified squamous epithelium. That is the reason it is called as epidermoid cyst. The content of this sebaceous cyst is nothing but sebum. As we said, it is a distension cyst, right? It is a retention cyst. So it has its own fluid. It has its own productive material, that is nothing but sebum. This sebum is usually yellowish in color, and it is also a pultaceous material, nothing but a toothpaste like material. And common sites that we actually encounter of this sebaceous cyst is nothing but wherever there is more amount of sebum glands, like this, nothing but your hair, scalp. Scalp is the most common area for this sebaceous cyst, usually the neck occipital region, and also in the axilla region. We can see in the scrotal region also, most commonly sebaceous cysts are seen. However, sebaceous cysts are not found at the areas where there is no sebaceous glands, that is nothing but on the soles of the palm and on the soles of your feet. Okay, we don't find this sebaceous cyst. Okay, sebaceous cysts are not at all seen in these regions, in your palms and also in the soles. Also commonly seen in face region also. When you're talking about the clinical features, remember I talked about punctum, right? Punctum is nothing but the opening. It is opening of your sebaceous gland. This punctum is usually present in case of sebaceous cyst. Punctum is present, and it is usually that bluish discoloration is seen, and the cyst is usually smooth and it is softer in consistency. It also ranges from few millimeters to about 2 to 3 centimeters in size, and this cyst has a characteristic feature that it adheres to underlying skin, and it is it is adhering to the skin, but it's not fixed to underlying structures, and it is soft in consistency. It shows two particular signs. One is sign of molding and sign of indentation. Sign of indentation is nothing but when we press the cyst, we can see the indentations present on the sebaceous cyst. And sign of molding, it can take form into different shapes also. That is nothing but sign of molding. And when we are talking about transillumination, again transillumination is negative because of the presence of this sebaceous material. Because of presence of the sebum, transillumination test is again negative in these cases. And coming to the management is total excision again, and this total excision can be of two different types. One is completely excision, that is dissection method. In this dissection method, what we do is we give an incision on the skin and completely remove off the sebaceous cyst. Second method is incision and avulsion method. In this incision and avulsion method, what we do, we give an incision on the cyst, on the surface of the cyst, and we open it up. Okay, and we remove or squeeze out all the material that is present within the cyst. We'll take up a forceps and try to pull all the lining by avulsion. Okay, and while pulling it, we are trying to avulse the whole of the cyst lining there. This is called as incision avulsion method. Incision will help in squeezing out the material, and avulsion is nothing but we are removing the cyst with the forceps through avulsion. The whole lining is removed with this method. However, dissection method is very useful in preventing recurrence. Some of the cysts are again, they recur in nature, they are recurring in nature. Hence, when we completely dissect it, recurrence is less when compared to that of incision and avulsion method. As I said, sebaceous cysts are very much common in the scrotal region because of multiple sebaceous glands that are present there. So how do we actually treat? If there is only one single cyst, sebaceous cyst, excision is better. However, if there are multiple cysts on the skin of the scrotum, excision of the cyst along with removal of the part of the skin that has been involved is helpful in case of managing this scrotal sebaceous cyst. Now, when you're talking about the complications of a sebaceous cyst. So the primary complication of sebaceous cyst is again infection. These sebaceous cysts has more prone to infection. This is because most of the patients, what they do is whenever they find a sebaceous cyst, they try to puncture it with the fingers or the nails. So this will cause secondary infection, and this can lead to persistent, continuous oozing of or continuous suppuration, leading to further infection. It can lead to abscess formation or an ulcer also there. Ulceration is again another complication where we can see in the sebaceous cyst, where we can see a particular thing called as Cox peculiar tumor. After an ulceration, there will be excessive granulation tissue formed, and this excessive granulation tissue will form into a fungating structure. Okay, that is nothing but Cox peculiar tumor. And we have sebaceous horn. In somewhat bigger sebaceous cyst, there will be a punctum opening, right? The fluid from the sebaceous cyst will come out through this punctum. In some cases, it gradually gets hardened up, leading to a hard structure within this punctum. Then it resembles like a horn. This is called as sebaceous horn. And we can see calcifications as one of the complications in case of sebaceous cyst and malignancy. However, malignancy is not so frequently seen. Usually, very rarely seen. If at all we see this kind of sebaceous cyst turning into malignancy, most commonly it would be a basal cell carcinoma. Usually sebaceous cysts are not very much, they doesn't have so much of malignant transformation. If it has, it usually comes out as a basal cell carcinoma. So this is about various types of cysts we have on the skin. We have seen about dermoid cyst, various types of dermoid cyst, and we have seen about sebaceous cyst and the management. Hope this would give you a proper insight into various types of cysts present on the skin. In our next lecture, we would see about various types of cysts involving the oral cavity, okay, in the bone and also the oral cavity. This will give even a better details into what kind of cyst we have there. Thank you.